I'm welcoming you to the 17th webinar. The 17th webinar in Peer Support Services. This one is going to talk about the Veterans Administration and what they have been doing in the Veterans Administration in terms of peer support services. When signing into the webinar website, please be certain you enter a telephone number without an extension for immediate callback. The audio portion of the webinar will be on your telephone. Okay, there's nothing we can do about that. That's the way the system operates. And it saves you from having a long-distance call, because the system is calling you instead of you calling the system. Okay, as I shared with you, all of your phones are muted. They will stay muted. If I hear any background noise, I can force mute you. I don't like to do that, but unfortunately, we've had so many problems with delivering the webinar with background noise that people weren't able to hear what was going on in the webinar. So we've taken and used the policy of muting the line. I'm Peter Ashenden. I'm the Director of Consumer Affairs from Optum Health. Optum Health has done a partnership with the National Association of Peer Supporters and International Association of Peer Supporters, and our partnership has been that we're allowing N.A.P.S to take and use our format, our WebEx format, as a way of taking and bringing forward their webinars. So it's their content material, but it's our platform that allows all of you to be able to participate in this, and participate at no cost to you. So we're very pleased to partner with Steve's group. He's done a fantastic job of bringing his organization along, and we're glad that we could take and be supportive of that. Steve, is there anything else I should mention before we turn it over to Dan?
I just would like to thank David Barker from Creative Media, who helps us archive these webinars. He's done an excellent job, and we really appreciate that.
Well, David, thank you very, very much. As Steve, as I frequently tell you, it takes a village to raise a child, and it takes a village that can get a webinar off the ground. So thank goodness we have a village that we can count on, because they always come through for us. So without further ado, Rita, are you on the call?
Yes, I am.
Okay. One of the questions that always get asked when we get started is, how can people get a copy of the PowerPoint, and how can people take and get their document that they've attended this webinar? Do you want to give them that quickly, even though we have it in the slides later on?
Sure. We have a 5-question quiz that helps us to verify that you actually attended the webinar. And then at the end of that quiz, there's a link to a self-check page where you can put your answers. And at the end of that self-check, you can click a link to get a PDF copy of the PowerPoint slides.
All right. Thank you very much, Rita. I appreciate that. As I said to you, it takes a whole village to raise a child. So at this point, what I'm going to do is I now have it on the slide that Dan is going to be starting with. I'm going to be perfectly honest with you. Dan's laptop would not allow him to download our WebEx information. So Dan is by telephone linked into us so that he can take and deliver this presentation to you. We had to get mighty creative this morning to make this happen. But Dan, I welcome you. You are an astute, incredible gentleman with incredible skills and incredible passion of changing the system. And you certainly have been a mover and shaker in changing the VA system. And I thank you very much for the work that you've done. And I thank you very much for your time and being willing to take and share your time with our audience. So, Dan, take it over.
Thank you, Peter. Those very kind words. As you were mentioning, it takes a lot of folks to do good things, and I've been blessed with a lot of support from colleagues outside the VA as well as inside the VA, as I've been working on this project for 7 years now. So without further ado, let me kind of jump in, and we'll go through a little bit of that history along with our present situation and where we're headed. The slide that we have up is just the opening slide, and you'll see it's dated today's date. The rest of the slides are actually dated a few months earlier because I borrowed these slides and neglected to notice that there's a different date on them. So let's go to slide number 2. The objectives for today's webinar is I hope I can relate to you the importance of systems change and help you understand how that happened in the VA, to understand the importance that peer specialists have in the VHA mission, and to provide you with information concerning the implementation issues and supervisory supports, as well as some values that we have for our peer support staff. Slide number 3. Prior to 2006, the VA functioned pretty much as any other traditional medical modeled healthcare organization. The Veterans Healthcare System hired mental health professionals, represented by those 2 blue ovals, and then veterans were kind of on the outside of the system, and they came to the VA for health care. But along 2005 and 2006, the winds of change were blowing quite strongly, and VHA mental health care went through a transformation in which it started to implement some recovery-oriented services, which included local recovery coordinators being assigned to each medical center to help all the mental health professionals at each location understand what recovery was all about, and not according to a medical model of being cured, of stopping symptoms, but the progressive changes that take place in a person who isn't in recovery. So they had a local recovery coordinator assigned to each medical center. They also started forming veterans and consumer advisory councils, which our goal is to have one at every medical center, and to transform the old day treatment centers, commonly referred to as day wasting centers, to something that was much more functional, skill building, and recovery oriented. And to this date, just by the way, VHA has done that. There are no more day treatment centers a la the old model, but now they're all psychosocial rehabilitation recovery centers. We also have the peer support program, which I represent, and I think that covers our psychosocial rehabilitation and recovery effort from 2006 on. So now we have peer specialists that kind of sit there in the middle between, go to the next slide, please, Peter. Slide number 4, you'll see that right in the middle between veterans and mental health professionals, and within the Veterans Healthcare System, are peer specialists. Veterans who are in recovery from mental health conditions and or substance use disorders, who sit on our treatment teams alongside of the mental health professionals and alongside of the veterans. They're an advocate for the veteran. They also help interpret some of the experiences that our veterans have, which our mental health professionals may have some challenges in understanding, but because of our peer specialist's unique role in having had a mental health condition themselves, are often able to use language and kind of refocus the mental health professional off of some of the more traditional interests that they have in terms of symptoms and hospitalizations and trying to look for non-recovery oriented items to working with the veterans on their own particular recovery goals, and peer specialists have been instrumental in doing that. So next slide. In 2012, I started in my job in 2007, and right from the get-go, we had a very limited and inappropriate classification for peer support staff. When I came on, there were about 130 peer support technicians. These were peers that had come on in a technician role, which meant they actually were supposed to be able to take vital signs, blood pressures, pulse rates, and all that good stuff. And we said, why in the world would we want a peer specialist to be able to do that? That's not what peer specialists are supposed to be doing. So we realized that our system had old, archaic qualification standards for the kind of thing that we didn't want them to do, and so we decided we're going to change that. Well, being new to the VA, and not new to the VA, but new to this position, and never having tried to change a job description before, I had no idea how long it would take. But from 2008 through 2012, I was working on it. And we worked on it with HR folks in the central office, and it was quite a battle. There were a number of obstacles and challenges. The VA's qualification standards are a subset of the Office of Personnel Management, which is a huge federal human resources organization that covers all of federal government occupations. And they couldn't, for any rhyme or reason, understand why we would want to hire individuals who had mental health conditions and actually use the mental health condition or being in recovery from one as a qualification for the job. Fortunately, there was legislation that was passed which made that a requirement, and so they finally went along with us. And as I say, it took 5 long years, really. But in the summer of 2012, we had established a new classification, and it was still in the social science, or still in the technician series, but we were able to get it into a social science aid and technician series, which meant that it didn't have to learn how to do blood pressures and all that good stuff. We could more or less tailor the job description, which we did. And we also realized that one of the motivations in getting this job description passed at that time was we were going to have funding to hire 350 new peer specialists to go with the roughly 230 that we had on board in 2012. And so we really needed a new job description to get new folks hired. And with hiring 350, we realized there might not be 350 veterans out there that actually had a certification, because that was one of the legislative requirements. So we asked HR if they would give us an apprentice position, which meant we could hire someone temporarily for a year and certify them. And then after their year, we could hire them on as a GS6 peer specialist. So as that was starting to roll out, and you can see on this slide what the requirements were. On the next slide, I'm going to talk about the wages, but before I talk about the wages, I just want to say that in September of 2012, President Obama issued an executive order to hire 800 peer specialists. So that was 450 more than we had been planning on hiring. It was a great boost to our program. The veterans organizations, Congress, and the White House were all very happy, as I was. And so we started this massive hiring effort under the new classification between September of 2012, and the requirement in the executive order was that all these folks had to be hired and trained by the end of December 2013. So we basically had 1 calendar year to hire 800 folks and get, if we didn't hire all 800 certified, whoever wasn't certified, we had to get certified. And lo and behold, we accomplished that. And one of the reasons, I think, is you can look at this career ladder and a real living wage slide. In the VA, we have 21 different networks that are geographically distributed across the country, and in Hawaii and Alaska, Puerto Rico, and each area is a geographical locality pay stipend that goes along with what the base is for whatever grade and step. So we use the Atlanta, Georgia general schedule, which is a higher area because of the cost of living. And we looked at what peers were making in the private sector, and the median salary for a certified peer specialist in Atlanta is $27,682. And you can see that in the VA, just starting out, even as an apprentice at the grade 5, step 1, that it's $5,000 more than the median salary for a non-VA peer specialist. And then as you go up the ladder, 6, 7, 8, 9, and those grades are about 1 year in between before you can be promoted. So the GS6 grade is kind of equivalent to having a college degree, even a master's degree, and being able to work in VA. So for us to have been able to accomplish getting these grade series for a peer specialist without there being a requirement for an education, but having lived experience, was really quite an accomplishment, one that I don't think has ever been done in VA and may never be done again. But we're very pleased that we're able to offer a good living wage to peer specialists, veterans in the VA. Then on the next slide, you'll see the distribution of peer specialists by those networks. VISN stands for Veterans Integrated Service Networks, and that may be undergoing a new designation with the new Secretary of Veterans Affairs, Bob McDonald. We don't know if we're going to keep the same structure of Veterans Integrated Service Networks. There may be some different regions identified, different nomenclature, but at this point in time, we distributed those 800 positions where we looked at each network and we examined how many veterans with mental health conditions were being served. And certain networks, have a higher concentration of veterans. So, for example, you'll see VISN 2 is one of the smaller networks. It covers upstate New York, and they were only required to have 16. And you look at, say, VISN 16 or VISN 8, those are both networks in the South. VISN 8 is Florida, southern Georgia and Florida. VISN 16 is around the Gulf Coast. There's a very high concentration of veterans, so they were required to have more peer specialists. So that's the required column, but if you look over in the third column, the existing number of peers, when we last looked at this, you can see that in just about every network, they exceeded the required number. So we funded 800, but there are an additional 171 peers across our system that were hired out of the local VA funds because they realized what a great asset peers were and brought added value to our treatment and recovery programs. On the next slide, some of the implementation issues that we had as we started to bring these peers on, especially with the influx of 800 a couple of years ago. It really depended on the perspective of the local VA and the networks where these peers were being placed, because there was some stigma and a resistance to change. The stigma issue I'm going to talk a little bit about later on in this presentation. But the resistance to change is a common construct, whether you're talking about peer support or any systemic changes that you want to incorporate. Most folks will think that we're already doing pretty good the way we're doing things, and why do we need to change? Or they'll say, well, we're already doing that. And in fact, many folks, when we said that veteran peer specialists brought a veteran-centric perspective to the treatment of veterans. A lot of folks say, well, we were already patient-centered. We were already focusing on the veteran. What does this mean? So the perspective that people have is one implementation issue. Also, this was a new position that we put on our treatment teams. Our treatment teams usually consisted of a mental health professional, either a psychologist, psychiatrist, MSW, psychiatric social worker, and in some cases, mental health counselors, substance use disorder counselors or addiction therapists, and then sometimes, depending on the setting, an occupational therapist or physical therapist, manual arts therapist, depending, again, some teams were working with veterans who had both PTSD and spinal cord injuries from combat injuries. So you would see those kinds of teams where you would need physical therapy, occupational therapy, manual arts, even recreation therapy in spinal cord injury units and prosthetics units. And in our PRRCs, where we were hoping to really boost community integration, getting veterans with all kinds of mental health conditions, including PTSD, back into a functional and contributing role in their communities. So having a new position, a peer specialist, an individual who maybe prior had received treatment by that same mental health team in a facility, there were a lot of questions, some resistance due to dual role relationships, role confusion. That guy used to be my patient. Now he's sitting next to me as a colleague. And assuredly that happened with our peer specialists as well. Sometimes sitting on a team where a former therapist was, and then having to discern how to advocate for the veterans they were working with, sometimes in opposition to the perspective of their former therapist, which is a hard role, as many of you might be able to agree with. And that's one of the reasons why our policies and procedures actually advise against hiring a veteran who formerly was served in that particular program in the recent past. So then understanding the new peer specialist role, again, mental health professionals have not had a lot of training or understanding of what a peer specialist is supposed to do. So we had to roll out a lot of training, a lot of webinars. We had some conferences for mental health staff as well as peer specialists. And then writing an implementation toolkit about supervision and how to implement peer support effectively in our system. So on the next slide, we told our staff, and we tried to present various training mechanisms and collaboratives to show that peer support providers are better able to empathize, access social services, respond to client strengths and desires, and be tolerant, flexible, patient, and persistent. And these were attributes that were the outcomes of some studies that have been done on peer support. Further, on the next slide, or on number 11, mental health providers have perspective on individuals with mental health problems as well. There was a recent study that was published in April of this year that compared the American public's perspective and mental health professionals on attitudes towards people with mental health problems. Now, interestingly, individuals who worked as mental health providers had significantly more positive attitudes toward people with mental health problems. However, there were some providers that had some concerns about, or had some conceptions about people who have schizophrenia as being dangerous and they desired to have social distance from those patients. And so that was concerning because many of the mental health professionals that responded that some of the vignette characters that this study showed them were likely to be similar to having similar diagnosis to other veteran peer specialists who were working alongside of them on their treatment teams. And so if in employment situations, a lot of those mental health professionals desired social distance, therefore the mental health professionals sitting on our teams may not be as comfortable in working with peer specialists who have certain diagnosis of serious mental illness, such as schizophrenia or bipolar disorder, PTSD with severe manifestations of symptoms, other psychoses. So that being the case, we have tailored a lot of our learning opportunities and our local recovery coordinators to be involved at the local level with helping our providers understand what their perspectives actually are. And once acknowledging and understanding those perspectives, they're in a position to better understand and be able to work with the peer specialists who are on their team. Obviously, if we had it to do over again, it would have been wonderful if we could have done all of that work ahead of time. But the president's exec order and the rollout of hiring happened so quickly that getting all of those folks on board and trained really was the priority. And so we are still in process of helping our teams function optimally with our peer specialist staff. So what we tell folks, we go to the next slide, Peter, recommendations for peer specialists and supervisors. On this slide, you'll see a soldier marching at the tomb of the unknown soldier at Arlington Cemetery in Virginia. I hope...
Wait a minute, Dan, hold on. I'm not on the same slide you're on. The slide that I have right now is mental health providers' perspective on individuals with mental health problems.
Okay, we're 2 slides down. I apologize. Maybe I didn't tell you to change the next slide.
Okay, now I'm where you were at. I now have a soldier walking across the screen. I'm sorry. We'll have to be careful on the next slide stuff.
Well, we're almost to the end, so we're good. You've been doing a great job.
Sorry about that.
So on this slide, as you see that soldier, I think all of us, veterans or civilians who've never served, but perhaps having had a family member or serve, we will recognize here the dedication and devotion that our service members have in protecting us. And this is a picture which symbolizes a tireless, consistent vigilance over a tomb of an unknown soldier, but our service members in all of the branches of the military are constantly serving our country to provide that same level of protection, of vigilance, of caring. And in order to do that, it really takes courage, humility, and patience. These are 3 attributes that I feel are extremely important to being a good soldier, airman, naval, Navy man, or sailor, or whatever branch of the service you are in, or people have been in. And it also, I think people will recognize these are great qualities for citizens, people, whether you're in the service or not. And I'm going to bring it home here and say that it really takes a lot of courage for peer specialists to get dressed for work and go out to work every day. Our peer specialists, the majority of them are all full-time employed. Many have given up Social Security disability or may have had their service-connected compensation reduced because some veterans with 100% service connection have a 30% employability factor, which means if they go to work and they're able to work, then they only receive 70% instead of 100%. So at great cost, in some cases financial, and just to deal sometimes with symptoms of a mental health condition, of getting to work. Transportation is sometimes difficult depending on where you live, and having the kind of courage that it takes to go to work, and then when you get to work, finding out that there are some members on your team or maybe other professionals in the hospital who don't understand your role there, may wonder why a patient who has a mental health condition, and because a person with in VA, anybody who's a peer specialist has to have or be in recovery from a mental health condition. So just by virtue of your job title, people know there goes a guy with a mental health condition. So it's very humbling for our men and women to go into work and then put themselves out there and work alongside of others who have degrees, major degrees. We're talking doctors and also psychologists and professional degreed individuals, and it takes courage and humility to sit in these team meetings, and sometimes, in traditional medical model-oriented team meetings, a mental health provider may use non-recovery language, prejudicial language that's hostile and stigmatizing. It's just been the way that they were taught, the way that they've always spoken. And so for a peer specialist who has a mental health condition to hear another professional on their team talk about another veteran in that way, say, oh, this guy's really crazy, frequent flyer, he's always in and out of the hospital, he can't get it together, he doesn't seem to be very motivated. Hearing all that stuff, I think for most of us who are in recovery, makes us want to jump up and scream, but instead our peer specialists very respectfully, tactfully, and humbly talk to the team about using recovery-oriented language and bring perhaps a different perspective about why that individual is coming into the hospital so frequently, because they have had a similar experience themselves. And it also takes patience, because it takes a long time for change to take root and to sustain it. So sometimes, you see eyes rolling, or you may hear whispers, and it really takes courage to keep your mouth shut, humility to speak out in a respectful and tactful way, and patience when you don't see results right away. But our peer specialists who do that have become the most respected and cherished peer specialists in our system, and I get calls, and I'm told about how good a job these folks are doing. And on the other side of the coin, I want to point out that while, at least for me, folks, I don't know how it is for the rest of you all out there, but being a person in recovery themselves, and having been on both sides of the fence in providing care and having been a recipient of care, and I did that for a long time without acknowledging to anybody that I was in recovery, so no one knew that I worked with. But I have been part of that system before, and so I know how people have been trained to keep their distance from people with mental health conditions. You can't get too close to a patient. You don't disclose your own personal issues. Basically, you try to help without being known as a person. And so I, having had some of my own providers for my own care, being so distant and so detached, I would get really angry, not feel I was being listened to. I think if any of you were at an N.A.P.S conference that I spoke at, I may have said this at one time a psychiatrist that I was talking to was falling asleep. And so I had a lot of issues with providers, even being in the system and being one of them. So I know how supervisors who are mental health providers may feel about patients who, like me, maybe are being now demanding, not just sitting back and taking anything the way that we used to, advocating for ourselves and other patients, that according to their training, we're being sort of non-compliant and resistant, and we're not behaving the way they were told that good patients behave. So now they're having to do a big switch and have the courage to say, hey, it's okay. These guys are really doing something that's transformational. I'm going to listen to them. I'm going to try and not do a knee-jerk reaction from what my training taught me. So and it takes courage for them in a team meeting to listen to a peer specialist. And if another mental health provider is talking against them, to say, hey, hold on, you guys got something. Let's listen to them. So that too is courageous, and it also takes humility. And our providers and supervisors are going to have to be patient, because a lot of us who are peer specialists and come into the field are doing so without having a lot of experience and understanding of what our roles are. Let's face it, the certification training programs that we go through are usually pretty short, and the majority of our experiences have been from living with a mental health condition. And we don't have all the resources and skills that we really need to adapt to the role of being a paid consumer provider in a sometimes traditional medical model-oriented system, even one like the VA that is transforming and has come a long way. So it really takes patience for all of us to work together. So I point these three attributes out to you and hope that we do have a spirit of cooperation and mutuality in working with providers wherever we are, to help them to understand our roles, and for us also to be able to relate our concerns in a way that helps the people that we serve. The last slide here is just the next steps of where we are going. We are working with the Department of Defense to operationalize a memorandum of understanding that will help service members who are being discharged to become peer specialists in the VA, because you do need to be in recovery, and the time limit on that for our HR purposes is for a year, and it's the mental health professionals who do the interviewing of the positions who determine whether or not a person has been in recovery for a year. And so our service members who are discharged, have a mental health condition, will be showing them how they can get into our system and get certified and trained, so that if they're interested, they can become peer specialists. Also, it's always an ongoing effort to make sure that the competencies that the VA has determined are necessary for peer support work are up to date, that they're appropriate, and that there are places that certify using those competencies. So we are evaluating those. We have a team that looks at those. We have a contract proposal or a request for proposals that will be going out soon. I say soon, probably next month. Many of you will remember that when we did a contract to train those 800 peer specialists, and actually we hired about 400 that were already trained and certified, but we did have to certify over 400. And the employee education system in the VA and the organization that won that contract, the DBSA, Depression Bipolar Support Alliance, just did a marvelous effort and accomplished getting all those folks trained and certified within that 1 year and 2 month window. So we'll be continuing to look at certification requirements. I think many of you know many more states have come on and being able to approve certain procedures and processes so that you can get a state credential. So it's really exciting to see that. We also want to expand peer support to non-mental health settings in VHA so that our peer specialists will be working in PACT teams, patient-aligned care teams, primary care specialty clinics, and they'll be delivering whole health counseling and support to veterans who are trying to lose weight, deal with diabetes, have a number of other unique chronic health conditions. We're going to do that through 25 pilots that will be, again, we'll send out a request for proposals, and 25 sites will receive funding for 2 peer specialists to work in non-traditional mental health settings. I would be remiss if I didn't also throw in here that one of the neat things that's happened this year is due to the efforts that our organization made with the Uniform Claims Committee to establish a provider classification for peer specialists and getting the support of some private sector organizations, 2 of whom I'm having the privilege to present today with, Steve Harrington, your fearless leader, and Peter Ashenden from Optum Care, along with Larry Fricks and some others, were very supportive of that effort. And lo and behold, now peer specialists do have a provider classification which places them at the table with other providers of care and will allow them in systems for Medicaid reimbursement and private health insurance for those organizations that will pay for peer support to be able to have their own classification. And in VHA, that means we're able to capture workload much easier so that we can justify and gather data that will help us with program evaluation, perhaps research as we go forward. And we will also be expanding our delivery model, which has traditionally been face-to-face. We're now doing telephone, PC, smartphone apps. So either through telephones or personal computers. We are now doing care to veterans that ordinarily wouldn't be able to get out into our treatment communities, but because of the electronics and the telecommunications, they're able to participate in peer support as well as other treatment activities using these means. So that's the end of my formal presentation. I know I've just went on and on about a lot of different things. I hope some of it's been helpful, but I'll take questions at this point.
Dan, thank you very much. You did an outstanding job of bringing forward where the VA is at, how they're moving forward, and what their plans are for the future. So we thank you very much for that. I'm going to start with one question that Steve doesn't have, and that is, Robert's asking this question, does less than dishonorable discharge include general, undesirable, and bad conduct discharges in qualifying for peer support positions?
That is correct. The only discharge that would prohibit a person from being qualified is a dishonorable discharge.
Okay. Thank you so much for clearing that up for Robert. Robert, if you have any further questions on that, please feel free to use the chat box. Steve, I think you have about 5 questions lined up.
Yes. There are a number of questions here. I'll take them in the order they came in. And Dan, the first is, I'm in a rural area. Is the VA considering outreach opportunities for community-based peer support services?
We actually do have some peer specialists doing work on our range teams. These are intensive care management teams for veterans in rural areas that need, traditionally they're called intensive case management services. In VA, we call them, instead of ACT teams, we call them intensive care management. And we do have some peers, not on all those teams, but on quite a few of them. And there is desire to hire more, but it all comes down to dollars and cents, folks. And it depends on your medical center and the resources that they have available. And that's one of the reasons why we are so excited about the Tele peer support model, because by using a PC or your smartphone, you would be able to connect. I know it's not the same as being face-to-face and being in a group of individuals, but while that might be a downside, the upside is there are some individuals who don't want to be in a group, in a room with other people, but they really want the support. So the telephone or the PC allows that. So pretty much it's going to be up the local folks, whether or not they're going to help in.
Hold on a minute, Dan. Hold on a minute. I'll take care of it.
Yeah.
Okay, are we ready?
Yep. So I think that's all I can say to that one.
Okay. We have a number of other questions. We're getting short in time. Can you please expand on what type of certification is required for peers in the VA?
The certification standard that the VA has to follow is based on public law, which says that veterans in peer specialist position must be certified by either a state-approved certification process or a VA-approved process. So if the VA puts out a RFP or an organization wants to be approved by the VA, they would have to meet the same standards that we would put out in that contract proposal, which covers about 35 competencies. And these competencies are pretty standard, I think, across most certification training programs. In the past, we have approved DBSA, Recovery Innovations, the Georgia model, Southeast Pennsylvania's, I forget the full name of that organization, but I think you guys know.
Mental Health Association of Southeastern Pennsylvania.
Thank you, Peter. So those have been approved in the past. They're not all approved at this time because we have a few new competencies and we haven't reviewed new applications. But those are VA approved, and then the state that you're in, if that has a state approved, in other words, either your mental health department, or some states it's a licensing and credentialing department that gives out credentials to all sorts of healthcare workers, then if there's an approved process that you have to go through and you get that credential, then the VA has to approve it.
I'd like to, Steve, I'm going to interrupt with a private question that didn't come to you. And that private question, they're asking questions so quickly, it's moving. All right, this is from Dennis. Dennis says, what will be the best way to pursue advocating for ourselves for a great advancement?
It would be the same as any other employee in the VA. Is your supervisor is the one who actually has to initiate a request for a personnel action. The individual can't do that themselves in our system. I mean, you can do it to make your supervisor aware that it's time and you're ready, but the supervisor is the one who has to really act on it. So the supervisor would then take that to their mental health manager and request HR to perform the action, which basically it's pretty easy with this particular classification. Is that you have done the work successfully at the lower grade for at least a year. Obviously, you have to be certified to advance, and then they should go ahead and promote. The limitation there is this: either a mental health program within a facility may not think the nature of the work is deserving of a higher grade. In other words, there are certain duties at the 7 or 6 level that they don't really feel the person needs to go beyond performing with higher degrees of independence and autonomy. So they feel that that person should stay at that grade. It's not required to promote folks, although we did request a series that had the targeted 9 grade, so that in most instances, VAs will want to promote people to perform at the highest level that they are capable of. And what I've seen so far is that is the case in most places. But I am aware that there are some places who say, well, we just don't have a need and we don't want to spend the extra money to do that. Now, in those cases, some folks have used union grievances. They've applied for other jobs to find a place where they can get their promotions. But that's really done on a local level within a network.
Okay. Dan, here I have a question. You may have already answered it here. This person would like to know how movement towards statewide peer specialist certification, like in California, might affect VA practices.
Well, that's a great question. I've actually had some discussions with the group that is trying to get state certification in California. We've had several conversations, and the interesting thing is that California has really reached out to the VA, and they seem to agree with our standards and are trying to promote those to become part of the state credential, which is I think is wonderful. In that way, certainly the VA would feel very comfortable with a credentialed or a certified peer specialist out of California. There are some states that have very non-challenging standards. It doesn't really take much to get a certification, and that's one of the reasons why, because we have to cover 50 states, that we recommend, or not that we recommend, we require that every peer specialist, regardless of where they're certified by, has to have 15 continuing education units each year. And that makes sure that they are learning, constantly improving, and coming up to the standards that our competencies require. So, we'd love to see every state have strong standards, standards that matched ours, obviously. But certainly it's helpful to veterans to have a way to get certified in their home state rather than coming on as a lower paid apprentice for those places that will hire an apprentice now, or to have to go to an approved VA approved training, which sometimes can be very expensive for registration, travel, hotel, per diem costs.
Dan, excuse me, Steve, before you go on to the next question, I have a quick question for you, Dan, that came into me. Do you allow non-military individuals to become a veteran peer specialist, a VA peer specialist? Non-military background.
Yeah, I think those two terms are contradictory. Non-military means you're not a veteran.
Right.
Right. So you cannot be, by law, you cannot be a peer specialist in VA unless you are a veteran.
Okay, thank you for clearing that up. I'm sorry, Steve. Go ahead.
Okay, we have one question here that has been generating quite a bit of concern, and that's in regard to the 1 year in recovery requirement. Some of the concerns is how is that measured, how is that determined, and there's some concern does the VA could look at previous mental health records, how exactly do they determine the 1 year recovery, and is there, I think the sense of it is here, is there some sort of delving into personal history through medical records?
That's a great question, and I hope I answer this and can convey that we had the very same concerns when we were developing the series and the interview questions, because the interview questions are a structured oral interview that every interviewer, every mental health professional who's hiring peer specialists are to use. And the only 3 questions that are asked on the employment application are you a veteran? Are you in recovery from a mental health condition or substance use disorder for at least a year? And are you certified? If you answer yes to the first 2 questions, you get an interview from a mental health professional if you're going for GS 6 through 9. If you're going for an apprentice position, you don't have to be certified. So you can say no to that 3rd question, that you're not certified. And if it's an opening for an apprentice, then you can be interviewed by a mental health professional for that. Then the mental health professional used the structured oral interview in which questions are asked which have been vetted by our general counsel to not be intrusive or violate ADA, Americans with Disabilities Act, or Rehabilitation Act of 1973, or any kind of discriminatory legislation, and be respectful of the person. So I can't actually say what those questions are because they're part of a structured oral interview that are private and confidential. So you apply for a job in the VA and you will get to hear what those are. But our mental health professionals are very sensitive, and because they are mental health professionals, they will be able to tell by virtue of the explanation in response to the questions whether or not a person is in recovery. There is no requirement. We fought against this. HR actually wanted us to have doctor's statements, copies of medical records be submitted as evidence of recovery. You will not be asked to present any of those things. The only exception being if a person were to apply to utilize a Schedule A appointment, which is a unique appointment authority in VA for people with disabilities to become hired without entering in a competitive basis, then you would have to show some documentation of your disability. But other than that, there is no requirement to show any medical record or talk to a doctor that you're seeing or anything like that.
Thank you for that explanation. We have a question. I've been reviewing some of the VA materials about peer support, and I'm very impressed. There's obviously been a lot of time and effort invested. Are these materials available for use outside the VA?
Well, certainly they could be, Steve. Most of our stuff is public domain because it's taxpayer money that went into developing the tools and materials. The bad thing is that most of it is located on a VA-specific intranet site, so it's only available to folks who can go on from a VA computer. It's just not widespread available, and I don't have a means at this point in time for finding a way to make it more publicly available. But certainly, if someone were interested in something specific, sent me an email, I would be glad to try and get that.
Okay, and perhaps that's something we can facilitate if there's enough interest between N.A.P.S and the VA. Let's see. Get here a.
I think maybe at this point it would be good to have Rita go over again how people can take and receive a copy of the PowerPoint and how people can take and get their certificate that they participated in this. Is that all right with you, Steve?
Yes.
Yeah, Peter, I actually have to run now and take another call, so thank you for having me on. I hope this was beneficial.
Dan, the feedback from the audience is phenomenal. It's over the top. They loved your presentation.
Well,
so thank you, Dan.
All you too. Have a Merry Christmas and a happy holiday season.
A very happy holiday to you too, Dan.
Thanks, Dan.
Okay, Rita, are you still on the line?
I am. So here's what you do. You go to the website. On the front page of our website, there's a link to the quiz. When you finish completing the quiz, then there's a link to the presentation slides and a self-check so you can check yourself as far as the answers to the quiz. And once that's done, I will be compiling all of the quiz information and sending it over to Steve, and he will be sending out certificates for all of the completed quizzes in about 3 weeks.
But it is possible for people to get a copy of the PowerPoint, correct?
Yes, just go through the quiz.
Okay.
It's on the last. There's a link on the last page of the quiz to a self-check, and a PDF of the presentation slides is on that page.
Thank you very much. On behalf of the International Association of Peer Supporters, on behalf of Steve Harrington, on behalf of Optum, we want to thank you all very much for taking time out of your very busy day to hear some new skills and some new ideas that we can always incorporate in the work that we're doing throughout the field. So without you, we couldn't take and do the work that we do. So I want to thank each and every one of you, and I want to tell each and every one of you that I hope you have an absolutely fantastic holiday. You're wonderful people that are doing great work, and keep it up, okay? I know it's hard, but keep it up because you're doing it. Steve, any last comments?
No, you expressed that so excellently. Yes. Thank you so much.
Okay. Take care, everybody, and happy holidays.